I want to talk to you about the psychological assessment, which is the first piece that we do when a person identifies themselves as needing some help. So we start with an assessment of that person, and we want to make sure that that is a holistic assessment in terms of looking at that person's psychological, physical, and social factors that might be influencing their individual's function, that person's functioning. Um, from there, after the assessment, then we develop a treatment plan, or we develop a diagnosis, and then from that assessment and diagnosis, we determine a treatment plan and what treatment modalities we're going to use in helping that person. So assessment can be done in one session. It might be done over a period of time, depending on the situation. But the first thing that we're going to do in assessment is the interview. And we would, typically the unstructured interview is the type of interview that is most commonly done. The structured interview is a is a more standardized series of questions that kind of have predetermined wording and order. So it kind of forces that person almost to like a yes or no answer. It doesn't give us a lot of information. Um, it gives us just really focused information. Where the unstructured interview allows for more of a conversation and discussion about what is going on with that person. It's also a time when we can establish rapport with that person. And that rapport is very important as we get into treatment. So, some of the things that we look for in an unstructured interview would be the person's reasons for being in treatment. So, what kind of brought them there? Sometimes that's kind of significant. So, if it's that it's court ordered, it gives you a little bit of indication about maybe how much that person's motivated to work on issues. If they feel like they're being forced, sometimes that might be an obstacle in getting help, um, or if they're seeking treatment themselves, and they might be more motivated that way. What symptoms are they currently experiencing? And then we get some history about health status, family background, and life history, things that have occurred to them in their life. And if I'm seeing kids, I usually will get a little bit more information about developmental history because that can give us some ideas too about some factors that lead to some of the childhood disorders. Also, oftentimes, as part of that unstructured interview, we might do a mental status exam. And this is really looking at where that person's thoughts are, how they're functioning at that snapshot. So we can do a mental status exam at any time, kind of looking at what that person's mental capacity is. And that might change depending on disorders or diseases. Um, Sometimes that mental status changes. So this gives us kind of a quick snapshot of where the person is right at that moment. So we'll talk about each of these indicators in the mental status exam. The first thing we look at is kind of how is that person appearing and what is their behavior like. So taking note of how if they're upkeep if they're appearing like they've been taking care of themselves, if they're groomed well, if they have good hygiene, or are they more disheveled and not really even able to kind of do some basic daily life skills. We also look at their motor behavior. So sometimes people will be real hyperactive or agitated. You might see them pacing or fidgeting a lot, making note of that. On the flip side, you might see people who have really slowed psychomotor behavior, where it's like almost difficult for them to walk across the room. And catatonia is when people really kind of have almost rigid behavior, so there's no movement at all. Okay. We'll also look at people's content of thought, so those ideas that fill their head, and some of the things that we're looking at in terms of abnormal thoughts might be obsession. So having a phrase or an idea that just is constantly in your head and causes the person distress. Delusions are false beliefs. So, and this usually occurs when people kind of get into that psychotic area, but a delusion is something where people have a belief of something that is false, that didn't happen. Um, if you look at the video on Peter, you'll hear some of his delusions regarding the dental work in his teeth and how that might be connected with NASA and his story. The thing about delusions is to that person, it is very, very true. Okay. Overvalued ideas is when the quality of their thinking is kind of odd or absurd. Um, Such as it again in Peter kind of looking at his plan at the end of the video when he kind of talks about his plan for a generator to kind of help with power. Um, and then finally magical thinking. So magical thinking is when people kind of will have a peculiarity. They'll believe that one incident might relate to another. So sometimes it's magical thinking, or sometimes you might think people might talk about it as, oh, this was a sign of something. The next thing we pay attention to is people's affect and their mood. So their affect is a term that we use that determines kind of the person's outward expression of their emotion. So sometimes I kind of think of it as how their emotions appear on their face. So sometimes their affect, you might see inappropriate affect, so they might be unusually happy for a situation that normally would be sad. So it's kind of an incongruent to what's being discussed. People who have a blunted or flat affect are showing no emotion. So they're kind of just almost a stone face. There's no expression to their face. On the flip side of that, exaggerated or heightened, over dramatic, sometimes it's really kind of animated. Um, affect you can see. Okay. And then that restricted range kind of means that there's just not a lot of fluctuation between the different ends of the affect that they're showing. Then onto mood. Mood is that person's experience of emotion. So it's that individual's subjective description of how they describe their mood. And when we talk about mood disorders, we'll talk about them on a continuum. On one side of the continuum, people might have dysphoric or unpleasant feelings. And then we kind of get down to depression at the very end of that range. Euthymic means that they're neither happy nor sad or content, but they're just content. And on the other end of that spectrum, we might have euphoric or kind of a cheerful, elated, possibly even a ecstatic mood. The other thing we look at and ask about is people's perceptual experiences. So some people, again, when they're having psychotic symptoms, they might have hallucinations. So hallucinations are false perceptions. So they use our senses, but our senses are perceiving things that aren't really there. Okay. So most common are auditory hallucinations or hearing voices, and command voices are those voices that are telling that person to do something. And usually those command voices are not nice voices. They can sometimes be kind of dangerous voices because they're kind of constantly in their head telling them to harm themselves or to harm other people. Sometimes people will have visual hallucinations where they're seeing things. Sometimes it's more shadows or kind of figures that they can't make out. And then less common are olfactory, which is your sense of smell, somatic, your sense of kind of pain and feeling, or gustatory, which are taste. So those hallucinations can occur. They're less common though. We also want to pay attention to that person's understanding or awareness of time, place, and identity. So are they kind of rooted in the present? Do they know where they're at? And then also looking at their thinking style and language. So some of the things that we can see in people's language styles or the way that they think might be some uncommon um, or abnormal ways of thinking. So looking again to in that video, you'll hear Peter have really loose association. So he'll be talking about something, and it'll kind of wander off into a way off topic, or he might have some illogical thinking. So there's a lot of contradictions into what he's saying. Other things that you'll hear in people's language might be clanging, which is like rhyming. So they might hear a word and then they kind of grab onto it and then they'll just kind of go through some rhyming. So they might hear the word think and go drink and and then they just kind of repeating that. Echolalia is something that kids will commonly do to kind of terrorize their siblings, and that's just repeating back what that other person is saying. And here they're not doing it to terrorize something, but they're just kind of echoing back what they hear. Pressure of speech is a common thing that we hear in people who are manic. And this is kind of a really kind of fast-paced speech. It's you can make out what the person's saying, but it's almost like the person is not able to get the words out fast enough. So there's kind of this pressure behind what they say. In the video that you watch on Sherry, you'll see her kind of on a manic side, and there's a little bit of pressure in her speech, but it can be even more so than what she displays. Other things that we're looking at is a person's motivation. So how well are they kind of motivated to do ordinary life tasks? Are they kind of engaged in life? And what's their motivation to kind of get better? We might look at people's sense of self. So this is any disturbances in that idea of who I am. So people who have depersonalization um, oftentimes feel like their self is outside of their body, or they might have some identity confusion where they really don't have kind of a clear sense of who they are. Things we might also do is look at their cognitive functioning. So you might give some different memory tests to see how well they're able to to use their short-term memory, and then just getting kind of a general idea on their insight and judgment. Okay. So after doing that initial interview, we might go on and decide that we want more psychological testing done. And this is where we use the standardized tests that give us some information about very specific things about that person. So when we look at those standardized tests, we want to make sure that they have some validity or that they're measuring what we want them to measure and that we're using reliable tests, which means that if the person took the test over and over again, they would get similar scores. So some common psychological tests that we use would be IQ testing, possibly might be something that we're looking at. We're going to kind of flip through this because the book talks more about IQ testing, but also some different clinical inventories looking at some different personality testing. The MMPI is probably one of the most common of personality tests. And that's got some different scores that kind of give you some personality profiles. And then the projective tests, which are diagnostic tests, such as the Rorschach. And in the folder too, there's some information. There's a good video on the Rorschach test and how that works. Finally, we might do some behavioral assessments. We might have people measure their behaviors to get a baseline of what's going on. We can have that done by self-reporting or through checklists. And then finally, we might do some more physiological tests. such as brain scans, imaging of that kind. So again, depending on what the need is, we might do